Welcome back, everybody, to the Building Lifelong Athletes podcast. I'm your host, Jordan Rennicke. Thanks so much for stopping by. If you're new to the podcast, the goal of this podcast is to help keep you active and healthy for life through actionable, evidence-informed education. And like I mentioned before, my name's Jordan. I'm a dual board certified physician in family medicine and sports medicine, and I love just educating and learning all of this stuff. So this is my whole goal here with the podcast, and we're starting a brand new season. This is season 6. We're talking all about the most common complaints that I see in clinics. So my job as a sports medicine doctor and primary care doctor, I'm going to go through kind of the most common complaints that I see and talk about the pathophysiology behind them, kind of what causes them. And then we will do a separate series all about treatments and kind of treatment programs and outline programs and all that stuff. So we'll go more into that, but this is going to be more about diagnosing things and whatnot. But let's get started. We're going to talk about patellofemoral pain today, which is super common, but patellofemoral pain syndrome. Let's get started. All right, so today we're going to talk all about patellofemoral pain syndrome, or PFPS. It is a super common musculoskeletal complaint, and we're talking all about common complaints, and this is definitely one of them. If you have not seen this yet, then you probably haven't been in clinic for very long because it is everywhere, or you just weren't quite sure to look for it, but that's okay. Fear not, after watching this, you're going to be on the look for it, that's for sure. But it's super, super prevalent, so I want to talk all about, what we do, how we find it, how to look for it, and yeah, just the general things about patellofemoral pain. So kind of let's get started here. First of all, how common is this? It's common. In general, MSK health is a big problem for a lot of people. There's hundreds of millions of people who have musculoskeletal complaints. Specifically, one article I looked at was looking at a big EMR study. So looking at 30 million people inside of an EMR, found that 6% of people had patellofemoral pain syndrome. If you extrapolate that, that's a whole lot of people. And so that is, a lot of people have this. That's just one segment. And then globally, they have this as well. And I just kind of throw in some numbers here saying that, just with MSK appointments daily, there's 100,000 MSK complaints daily across the UK. And in the US, there's 126 million Americans who have some sort of MSK disorder, costing about $213 billion annually. So billion with a B, that's a lot of money. So this is very prevalent and it costs a lot of money. It's not necessarily as expensive as like a surgery or something like that, but very important that we're going to see this. We are going to see a lot of it. And so the next question we kind of have is, how is it defined, right? So there's no real one definitive diagnosis, right, on this saying this is what it is, but specifically we think that it's non-traumatic. So meaning we didn't have an acute injury, kind of this diffuse anterior knee pain, and then it's worse with squatting, running, climbing, descending stairs, things like that. And so the three things, once again, no acute trauma. I mean, this came on insidiously. It's like, oh yeah, over time my knee started to hurt. 2, we have diffuse anterior knee pain. A lot of times those, it hurts here, and they kind of vaguely rub their hand in their whole peripatellar area. It's just kind of gross, yeah, that's it, or say it's under my kneecap or something like that, but just kind of diffuse. It's not like one spot here, hey, it hurts right here. It's kind of more diffuse. And typically things like running, squatting, climbing, stairs, going up or down. A lot of times down is a big thing. Down with hills, down on the hike is worse than going up. Things like that we think about hey, that's how we kind of, cue into it with our diagnosis and kind of the history, but that's what we think about. And moving on from how it's diagnosed, let's talk a little bit about anatomy first real quick. So anatomy, the patellofemoral joint, that is the patella, or, obviously the kneecap, and the femur, which is the thigh bone. And inside the femur, there's the trochlea, which is kind of like the groove that the patella sits in. If you look at here, we can kind of see, hey, here is the big diagram. This is the patella, and right underneath it is the femur. And underneath it, we have some articular cartilage in there, which the patellofemoral cartilage is actually the thickest cartilage in the entire body. And the patella sits right in there on top of the femur. So the patellofemoral joint is this joint right here going in there. And there's lots of stuff going on there, as you can see. Pay no attention to all those things. That's a Wikipedia image. But yeah, there's a lot going on there. And the purpose of the patellofemoral joint, right? The patella is an extension, kind of helps with extension of the knee, right? And the patella acts as a lever of the leg to kind of decrease force to extend the leg with the quad. So what do I mean by that? It kind of is used as a way it's a lever, right? To help pull. When the quads contract, that extends the leg, and the patella plays a big role in that. And on top of that as well, the patellofemoral joint and patella in general, kind of all this is stabilized by the quads, the patellar tendon, right down here, patellar tendon, quad tendon. We have a whole bunch of stuff. We have ligaments, medial patellofemoral ligament, which is important for patellar dislocations. We have all these tiny little ligaments. We have the retinaculum. We have all this stuff that's not necessarily indicated or shown here, but lots of things keeping this whole joint stable, right? Because this is inherently not the most stable thing. It does sit in a groove in the femur in here, but it's not the most stable thing and could be moving sideways or get dislocated. And so we have lots of little ligaments, and we have retinaculum, and all these things that kind of keep it in place to offer stability there. And, that's kind of the big thing when we're talking about, stability. That patella, not as stable as some other places, but it does play an important point, and it takes a lot of stress, right? We'll talk about biomechanics here in a second, but it does take a lot of load when we're doing things like running or walking and whatnot. And specifically, if we're looking at the biomechanics, one idea that people will talk about, this is by no way, shape, or form like definitive, like, oh yeah, this matters a lot, but something called Q angle, right? So Q angle, this is the angle formed from the anterior superior iliac spine to the center of the patella to the tibial tubercle. So this is kind of the picture. We're looking at the anterior spine, we're kind of getting there, and it kind of makes this Q angle. It goes all the way down, and you can see right here that, yep, we've got kind of this going from the tibial tuberosity through patella, like this kind of angle specifically. And this angle right here is this Q angle. And it's not really like super critical that you're like, oh, I know how to form and, calculate Q angle. That's not important. But what's important is just to understand the concept that this may lead to some issues at the knee from biomechanics standpoint. Once again, this is very like biomechanical model, meaning like, hey, because of this must happen. And we kind of know the biomedical model is not necessarily the best way to think about pathology or pain. So some people will say, like, oh, it's because of the Q angle. And it's not as simple as that, but I just want you to understand, talking about Q angle, there's a lot of mechanics that go into the patellofemoral joint. But this Q angle, it does kind of indicate like when you're pulling your quad, right, will have different forces depending on how wide your hips are or whatnot. And specifically, the higher the Q angle, the more laterally you have a patellar force, which could theoretically track your patella a little more laterally here. If you're looking at it, could go there, not quite sit perfectly in the groove. This is like what some people think may be causing some issues to that. And women have naturally higher Q angles at baseline. And so some people think that it makes a big difference, right? And it's kind of controversial though, right? There's definitely some newer literature that questions the idea that Q angle is super important and like the end all be all for things. I think we can all definitively say it's not the end all be all, right? Because not every person has a higher Q angle. Females have higher Q angles. Not every one of them is getting patellofemoral pain, and then some males do. So it's definitely not just Q angle, but from the biomechanics standpoint, the Q angle theoretically playing risk factor and kind of leading to that. And then other biomechanics, understanding that, hey, when we're doing lots of things like running and loaded things, that we're putting a lot of force through the patellofemoral joint. So you're kind of extrapolating that when you're running or walking, you're not just doing a, whatever the basic force is, it's multiplied essentially through your knee. And so it's undergoing a lot of load. That's a whole other topic in discussion and lecture, but biomechanics can play a role into patellofemoral pain, but it's not like necessarily one-to-one saying, oh, like I know that's it. And then speaking of underlying causes, as you can see here, there's quite a few, because at the end of the day, like nobody really knows. And that's the most frustrating thing. Some people say it's the Q angle. Some people say it's patellar maltracking. So we talked about kind of that patella sitting, perfectly in the groove. I always say like, this is it. And the patella sits right in here and it kind of sits in this groove perfectly. If you're a little off to the side, maybe that is leading to some issues with that. Not one-to-one once again, because there's plenty of people who don't have quote unquote perfect patellas or tracking, but don't get this. And so could be risk factor, absolutely, but doesn't seem to be slam dunk the only thing. Other things is some people say maybe it's stimulation of some nerve endings in the retinaculum or in Hoffa's fat pad or the parapatellar synovium. Who knows what? Some people say also it's because of, quad strength and balance, meaning, hey, your medial quad's not as strong as your lateral quads, and that's causing it. Others say ankle mobility restrictions, meaning we don't have much dorsiflexion, foot issues, hip or glute weakness. And as you can see, nobody really knows. That's really the big takeaway here is when you see like this many reasons for like, oh, this is why we think it's causing it. That means like we don't know. We definitely don't know. But that being said, all these are worthwhile to understand because everyone really presents very differently for this. And that's like the big take home we'll talk about in a second, is that treating this is very individualized. And so this maybe someone does have more of a issue with patellar maltracking. Maybe for them that matters. Maybe they do have, disproportionate muscle strength somewhere else. Who knows? It's very complicated. It's much, much harder than, just saying, oh, it's this one thing. But there's lots of underlying causes of why this could be. So just something to consider as well. And when we're talking about, different risk factors, right? A lot of times we're talking about female sex. We talked about why that might be with potentially the Q angle, but that's not the only reason. People who do lots of running, they do call this runner's knee, by the way. The other name for this is runner's knee. So when people are like, oh, like I'm running, I have pain, like, yep, makes sense. This is runner's knee. So if you ever hear that, that is a synonym, runner's knee, patellofemoral pain syndrome. Just a little side note, chondromalacia is very similar. Things present very, very similar to this, but the difference is, we'll talk about in a second, is there's no definitive changes on the cartilage with patellofemoral pain syndrome, whereas chondromalacia starts to have a thinning of the cartilage. So that one's not quite interchangeable. Essentially, how you treat it is interchangeable, but it is not quite the same. But runner's knee and patellofemoral pain, that's the exact same. And then we also may have some patellar maltracking issues, like I mentioned. But once again, how do we define that, right? What's normal? It's anytime we have these biomechanical things, it's like what's quote unquote normal, right? What's normal for you is not maybe normal for me. One thing that may be risk factor is sudden increase in activity level. I mean, this goes for almost everything musculoskeletal. Is if you just spike up your workload, saying, "Hey, like, all of a sudden I'm doing a bunch of running. I've never run before, and also I'm running, 50 miles a week." That is a risk factor for just lots of injuries, and so that may be also patellofemoral pain as well. Things people mention is maybe possibly quadriceps weakness, maybe having a flat feet or doing overpronation in your foot, or having dynamic valgus, which is where the knee goes in. We've talked previously about valgus, and what valgus is a lot of times that's kind of, if you think about your elbow, this is valgus for a pitcher going in this way. We have the distal portion going laterally and the more proximal portion going medially. Like dynamic valgus is your knee just kind of caving in over and over and over again. And so those are risk factors that we may have for that. I think that's fair to think, hey, everyone might have certain risk factors, but they're not definitely one for one. And then moving on top of that, then we talk about who suffers from this, right? Like who has this? And well, the answer is pretty much everybody, right? This is a lot of people. The classic presentation is going to be someone a little younger, right? Specifically adolescents, young active adults, maybe elite athletes, people who are doing a lot of work, maybe military recruits and females more than males. And I see this quite a bit as a sports medicine doctor in lots and lots of people, but usually it's more skewing a little younger. So like not necessarily adolescents, can go all the way down to adolescents. Absolutely. I see adolescents with patellofemoral pain. That's definitely something I see, but also into the young active adults. And it's something I see all the time, kind of giving them lots of issues. And so we have that. And then the next question is, well, how do we formally diagnose it? And there is no formal diagnosis. And that's kind of challenging, right? You can't get an x-ray and say, oh, this is it. It's really based on history and physical exam. So when someone comes to my clinic, I have to just take a really good history. I mean, a lot of the times you have the diagnosis before the history's done. You're talking to someone who's like, yep, military recruit, and I have to do a lot of rucking, and I have this anterior knee pain, all this thing, and the history is like you've already got like slam dunk diagnosed by the time they're done with the history. Obviously, you do physical exam and to corroborate and all that stuff, but history is really, really important, and it'll give it away quite a lot of the time. But there's no formal way to diagnose with imaging, and so it's a clinical diagnosis. And then when we're talking about how does it present specifically, well, there are different ways to kind of see that, and a lot of times it's going to be anterior knee pain. It's going to be worse with things like weight bearing and, or flexion of the knee. So essentially when we're doing squatting, running, lunging, all the fun stuff and the good stuff for you to get your heart rate up and to get stronger, can cause lots of issues. May have maybe knee pain with prolonged sitting. That's called the theater sign. So if you've been sitting for a long time, whether it's a student in class saying, hey, I get a lot of knee pain after sitting for a long time. That's called the theater sign, like you've been sitting in a theater. And a lot of times what's very interesting is I will see people say, my knee feels like it gives out. So they'll say it gives out. And that's a big thing, right? When you hear that my knee gives out as a physician, you're like, okay, well, first of all, that's not good. And second of all, what? I got to make sure this doesn't make sense. So then you pair back with mechanism, right? So the mechanism is not, hey, there's no trauma, right? So we're not like worried about ACL, but when you should give out, you want to make sure like the ligaments are good. So obviously you're testing for that every knee exam. We have other videos all about the knee exam and how to do that, but they may say like it gives out, and it's not necessarily due to instability, true instability in the knee, right? We have not had a multiligamentous knee injury. They didn't blow out their knee. A lot of times they just kind of gives out due to either it's quadriceps like inhibition, meaning essentially you feel pain in your body, just like, whoa, like just kind of relaxes. The way I explain it to patients is like essentially your quads are just like, nope, I'm out, like something's going on. And so that's like the giving out, but it's in no way, shape, or form like truly unstable. All right, so now we've talked about the presentation, and we mentioned that a lot of times the diagnosis is made by the history, but we want to do a physical exam as well. And so let's talk about the physical exam for patellofemoral pain syndrome. And first things first is you should not have swelling with patellofemoral pain syndrome. I'll just kind of read with that. If you have a truly swollen knee joint, that is not patellofemoral pain syndrome. You should be looking for something else going on. This is not PFPS. There's something else going on intra-articular. So first things first there. On physical exam, probably the best thing you can do is have them squat, whether that's a two-legged squat or a single-leg squat. That seems to be the best test to reproduce their pain. A lot of times that's going to be the one that's showing a lot of pain. So can you just have them squat, see how they're squatting. If they have pain, that's positive. You may have the patellar tilt, which is where we kind of grab the patella and kind of tilt it over to the side there. That can cause pain. And then we can have Clark's test, facets as well, or Clark's, where we're pushing down the patella and contracting the quad. And then we can also palpate underneath and do some facet tenderness. So essentially go underneath the patella. We kind of on the underside, we're palpating the medial and lateral facets and see if that has tenderness at all. And if I had to pick two, it would probably be, facet tenderness and squatting. Those are like the biggest bang for your buck. We do have lots of videos on physical exams looking at for patellofemoral pain syndrome specifically, but that's what we're looking at there is kind of when you have tenderness underneath the kneecap and pain with squatting, like right there, those two, obviously there can be other things. There's a big differential for anterior knee pain, but right away I'd be like, I'm thinking it might be patellofemoral pain syndrome. So that's kind of what we're thinking about. And then once you have this, you've gone through this, the question you might have is like, well, do I need to get imaging? And well, the answer is no, at least not to start. If it's persistent, may want to consider an x-ray to rule out arthritis, because that's really the big thing, right? You can have a similar presentation. This can look like arthritis, or arthritis can look like this, meaning you have this vague pain, insidious, we don't know what's going on, but you get an x-ray and they don't have arthritis and patellofemoral pain syndrome. So that kind of helps seal the diagnosis. But you do not need to get this first time in clinic. Or if you're a patient saying, hey, I think I need an x-ray to make sure something's going on, like, you do not need to do that. It's, save them the radiation. You don't have to do that, but you don't need x-rays. And the only time I ever think about x-rays for this is if it's not making sense, right? Something's going on. They're not getting any better. It's persistent. I will do it to rule out arthritis earlier rather than later, because that's my job as a sports doc, to make sure that, I'm not missing things. But you don't need to do it right away, especially in primary care. Like if you come and this is the diagnosis, like save yourself the money, the radiation, don't get imaging right away. And then for a treatment here, this is very challenging, can be very, very challenging at times. There's no, one size fits all treatment, unfortunately. And for me, I think load management is really the key. And when I mean load management, what I mean by that is that we're reducing irritating factors and then slowly ramping up later. So a lot of times what it is, it's kind of a mismatch, right? So you think, I want to do this, but your body's ready for this. And so this mismatch, I kind of put it, that essentially leads to an overuse, and that kind of leads to injuries. That can lead to different injuries all over the place, tendonitis and tendinopathy and all that fun stuff. But we treat them all very similar in that we think load management is key. So we reduce it down and then slowly go back up. And then if, that doesn't work, then we may think about specific mechanisms that may be happening, and kind of looking through, there's different guidelines, and we'll talk more about this in a future, lecture, talking all about, hey, treatment for this, but specifically getting them active. Physical therapy is usually a great place to start, or home exercises. But in general, like load management, that'll do it and then slowly build back up. But if that doesn't, then it can be more targeted. May have to go after specifically glute or quad strengthening, meaning work on mobility or flexibility for some people, specifically like in the ankle. May need multiple rounds of physical therapy with, varying emphasis, meaning, hey, we tried these things this first time and something else. And this can be really challenging. And one thing you can do that's awesome for your patients is, hey, just lay an expectation, right? Understanding, like, when I'm seeing patients, I say, hey, this didn't come on in a day, right? This took years and years and years to develop, or many months. It's just kind of been building on and status. However long, it didn't happen overnight. And so why would I expect physical therapy to work overnight? You don't. And I wouldn't expect that. And counseling them is very important. Say sometimes this can be annoying. Like I've seen this, I've actually dealt with this myself, and wasn't PT for like 8 to 12 months. Like it took forever, and just slowly kind of building things back up. And so just giving the expectation. Nobody wants to hear that, right? Like it's not like you're not going to be their favorite person when you say, oh, it might take like 8 to 12 months. And they're gonna be like, well, I'm not doing that. But that's beside the point. Just setting expectations. That it's not like, hey, 6 weeks, if you're not better, come back. Like, no, I don't expect you to be better in 6 weeks. I think you should hopefully be a little bit better, but I don't expect you to be like markedly better necessarily. So really given a time frame of, I would say like at least like 12 weeks. Like give them at least 12 weeks. That's 3 good, months of strong physical therapy. But that's essentially like one of the biggest takeaways here is, we're reviewing here patellofemoral pain syndrome, super common. We see it all the time. It is everywhere. It's kind of this vague anterior knee pain. X-rays are negative if you get them. It's not a way, hurt pain with squatting, running, lunging, things like that. And, on exam, we might have some facet tenderness or whatnot, a positive Clark test or Taylor, or a patellar tilt. Regardless, it's kind of a combo of history and physical exam make the diagnosis. And then treatment is really decreasing the load and then decreasing irritating factors, then bringing it back up and slowly ramping up, and then targeted therapies as needed with strengthening and whatnot. But active treatments are always going to be the best as well in terms of like having the patient be involved. But that's the general idea of patellofemoral pain syndrome. I hope that was very helpful for you. Hope you have a better understanding of what patellofemoral pain syndrome is and how to diagnose it and treat it. And that's going to be it for the podcast today. Thanks so much for stopping by. This is a little more medical, but I think it's kind of helpful trying to get this all together so you can understand what we think about as physicians and clinicians evaluations, but then as patients, the questions to ask and maybe even the tests you can do at home to kind of see, hey, might be going here. But if you did find this helpful, it'd mean the world if you liked the podcast and gave it a 5-star review on either Spotify or iTunes. That would mean the world to me. Or if you share it with a friend. I think that's the highest praise you could possibly give, is if you share it with a friend. So but thanks so much for stopping by. I really appreciate it. Now get off your phone, get outside, and have a great rest of your day. We'll see you next time.